I'm discussing the newer treatments for Parkinson's disease and with a specific focus on clinical trials at Evergreen Health. So, Evergreen Health is a public district hospital, and some of our activities are funded through the community by tax levy dollars. So, what that ensures is that what the hospital delivers is community focused and it is what the community wants. And consistently over the years, our community has said that they are interested in having access to clinical research. And, in fact, the community just increased, Evergreen was on the ballot for a levy lid lift, and which just passed. And so we continue delivering what the community wants, which is, clinical care within the community with access to clinical research. So we are located, on the east side, east of the lake. Our research department has been established since 1989, and we have clinical trials in about 14 clinical specialties. As far as movement disorders, we have 5 movement disorders neurologists, we have 6 neuropsychologists, 6 general neurologists, and 24 personnel in our research department to support our clinical research. So the trials I'll focus on today are categorizing into neuroprotective trials, symptomatic therapy, stem cells, and gene therapy. So among the neuroprotective trials, there's been about more than 70 clinical trials in Parkinson's looking for neuroprotection, and they've been going on since the past 60 years. Unfortunately, nothing has been successful so far. So there is currently no medication that is approved for slowing progression in Parkinson's. However, the search continues, and we've learned from each of the failures that have happened over the past 60 years. So currently, one of the trials that's going on is looking at antibodies to alpha-synuclein. We know that there was extensive search in Alzheimer's too. And then eventually, there was the anti-amyloid antibodies that were approved. And in fact, we were part of those Alzheimer's trials. So similar concept, except obviously the protein in Parkinson's is different. So in Parkinson's, we know we have aggregated alpha-synuclein. So this trial, which is looking at prasnezumab, is looking at a humanized monoclonal antibody that binds to the human alpha-synuclein, to the C terminus, and then it binds to the aggregated alpha-synuclein, which then is taken up by glial cells and hopefully eliminated. Now, the first trial that happened looking at this compound was Pasadena trial. Pasadena was looking more at safety, but one of the lessons, and it was also a dose-finding study. So what we learned from Pasadena study, which looked at 2 different doses of this compound, was that there was not a dose response, meaning that lower dose and higher dose seem to have the same effect. So because the safety profile was better for the lower dose, this lower dose is now being looked at the phase 2 PADOVA study, where patients come in once a month and they receive intravenous infusions of prasnezumab. And now actually patients have been transitioned to the open label study. And the open label study now has been extended for, earlier it was 3 years, now it's another 5 years. So we're getting long-term safety data for these patients. And the phase 3 study looking at the same compound is just going to start. Now, one of the unique things about this trial has been that it has allowed patients who are already on dopaminergic medications, low-dose dopaminergic medications, to enroll, which has been good because a lot of the trials in the past have only allowed patients on no therapy, no symptomatic therapy, or just on, say, MAO-B inhibitors. Now, what happens is that off the bat, when these patients enroll, oftentimes they're already struggling with, symptomatic treatment, and then you're trying to put them through the trial. while they're struggling with, and you're saying 6 months, 9 months, don't try not to start symptomatic therapy. But here, they can enroll in the study when they are up to 450 milligrams of levodopa. And one of the endpoints is to see in how much duration they have 5 points worsening on the MDS-UPDRS score. Now, this is intravenous. Now, in the long term, obviously, if things get approved, intravenous medications, having intravenous access, need for patients to go to the hospital or infusion center every four weeks might be challenging. So UCB is looking at an orally available, orally delivered compound. The mechanism is a little bit different, but again, similar concept, try to remove aggregated alpha-synuclein. So the UCB compound is oral inhibitor of alpha-synuclein misfolding and downstream aggregation. And they have, patients not on any symptomatic therapy, but in one group it started right at the beginning, and in the second group of patients there's a delayed start. And the concept is to see if there's the ones who start early, do they do better in the long run? Now, there has been this interest in kinase inhibitors in Parkinson's disease. We know that these drugs are used for leukemia, lymphoma, etc. But as far as Parkinson's, there's a thinking that activated c-Abl can lead to neurodegeneration through phosphorylation of parkin and alpha-synuclein, which then downstream leads to cell death through a variety of pathways. So the ProSeq compound, which looked at a kinase inhibitor, we did that about 2 years ago to see if it decreased the rate of progression. Now, that study did not show statistical significance in terms of motor function difference compared to placebo. And there have been other compounds also where they've looked at tyrosine kinase inhibitors. And though it looked promising, pretty much all of them, including nilotinib, have not panned out. So now there's another trial that's looking at combining tyrosine kinase inhibitors with JAK1 inhibitors. And the thinking is that the combination of inhibiting the two pathways may have additive effects. So the tyrosine kinase transduces signals from interleukins 12 and 23, whereas the JAK1 pathway mediates different interleukin pathways. And the concept is that if you do dual inhibition, you may have better efficacy in targeting neuroinflammation. Now, besides these, there's the immediate problems that Parkinson's patients have, which is fractures and falls. And currently, there's not a whole lot that we do differently other than, give them a walker when they start falling. But obviously, we want to decrease fractures because it's a major cause of mortality and morbidity in Parkinson's. So we know that bisphosphonates are used in patients with osteoporosis. But the Topaz trial was a first home-based remote. This was one of the largest home-based clinical trials that have been done in Parkinson's disease, in which patients, anyone with Parkinson's or Parkinsonism was eligible, and a nurse went out to the patient's home, and this could be in any state in the US. They were going out to Alaska, they were going out to really any states because the trial was contracting with local nurses. And the patients would either get a placebo or a one-time infusion of zoledronic acid. And then these patients were followed for 5 years through phone calls or through web-based questionnaire to see if they had any fractures and falls or fractures. And we are still waiting, the analysis should be out soon. And in this, patients were not needing DEXA scans, etc. So the concept is, if someone's got Parkinson's, and you can assume that they'll have some osteoporosis because there's decreased mobility, we know they have increased falls. Should we just routinely be recommending bisphosphonates low dose for these patients? So we'll see what this trial says. But more importantly, it laid the groundwork for one of the largest virtual at-home based clinical trials for Parkinson's. Now, a lot of patients with Parkinson's have non-motor symptoms that are problematic, like apathy or depression. And Light PD is an investigational FDA breakthrough device that is being developed mainly for non-motor symptoms, but also for motor symptoms in Parkinson's. And the device emits a blue-green spectrum of light, and that activates the melanopsin-containing retinal ganglionic cells to regulate the circadian rhythm, because this pathway or the retinal cells in the retinal ganglionic cells are found to be atrophied in Parkinson's disease, because the retina we know is involved in Parkinson's disease. Now, the device gets shipped to the patient's home, and it's more like moonlight rather than sunlight. So patients can actually look at the device, but they don't have to look at the device. They can just look in the general direction of the device. And they could be reading, they could be knitting or doing whatever. And as long as they face in that general direction for 1 hour, it's looking at two different wavelengths of these lights. And then virtually, these patients are followed at 3 months and 6 months to see if there is difference in their non-motor or motor scores. And the hope is that maybe it'll help with depression and apathy, which are hard to control symptoms in Parkinson's disease. Now, this is a phase 4 trial we are doing, and subcutaneous foslevodopa, foscarbidopa, which are prodrugs of carbidopa, levodopa. We did the phase 3 clinical trials that led to approval. So this is a continuous 24-hour subcutaneous infusion that delivers a combination of subcutaneous foslevodopa, carbidopa, and the device, the skin part of it can remain in for 72 hours. And we were part of the clinical trials that led to the approval. And now, because it was just recently approved, phase 4 trials are needed. And so we'll be following patients during the phase 4 trial to see how the real world experience with this device is. Meaning, some of the things that'll, in addition to motor, non-motor scales, some of the things that there's also interest in looking at these days is what is the healthcare utilization? Meaning, if patients are using devices that are better, sometimes more expensive than your traditional oral medications, overall, is there less cost to the health system in other ways, meaning less hospitalizations, less ER trips, less falls from off time. So those are some of the outcomes that we'll be looking at too. We recently completed the trials for infusion of apomorphine. We know apomorphine has been available as an as needed subcutaneous, as an as needed injection for treatment of Parkinson's. So, but though it's an effective medication, patients have had poor utilization of it, mainly because of the inconvenience of repeated injections. So this device is now, it's been available in Europe for a long time as a subcutaneous pump, actually for 20 years. But finally, it's been approved in the US. And so patients can there's a little applicator. They can inject the subcutaneous needle, which is just plastic. The metal part comes out with the applicator, and it's attached to this little pump. The whole thing looks like an iPhone. And the apomorphine is slowly infused into the skin. And this is an additive to their oral medications. So the Vyalev, the previous one that we talked about, is a replacement. So patients who are on the subcutaneous foslevodopa, foscarbidopa, For them, this is replacement. So it could replace all their oral medications. The apomorphine is an additive, low dose additive on top of their other oral medications. It could be agonists, it could be carbidopa, levodopa, it could be MAO-B inhibitors. Now, pros and like the side effects to look out for VYALEV, mainly skin reactions. So people can have inflammation, infection of the skin. So mainly skin reactions. And for apomorphine, skin reactions are mainly nodules. Tend to be less of a problem, but if you roll the skin, you can feel the nodule sometimes under the skin. So these are some of the things um, that we are looking for during the trials for what are the, and obviously, being part of neurology clinics, sometimes we are not the um, most knowledgeable about these skin reactions. So it's been a learning curve, learning how to identify differences in infection, inflammation, nodules, and know which ones to react to, which ones just to wait and observe. So I think in the future, we may need collaborations with possibly some dermatology clinics or maybe infectious disease, so that when we have more of patients on these devices, especially with the VYALEV, we have some colleagues that we can discuss how to handle skin reactions. But by and large, 90%, 95% can be handled in a neurology clinic. But if it proceeds to infection, then we need maybe our ID or our dermatology colleagues involved. Now, coming back to meds that are in clinical trials, just phase 2 and 3. Parkinson's patients we know have motor fluctuations. So after 5 or 6 years on carbidopa, levodopa, patients will sometimes have off times or they'll have dyskinesias. And currently, there's only one FDA-approved medication for dyskinesias, which is amantadine ER. So there's certainly need for more medications for motor fluctuations. And one of the trials we have going on is looking at a new compound, which is lenrispodom. And what it does is it is a selective inhibitor of the phosphodiesterase pathway. And this is an enzyme that when you regulate it, you modify the downtime second messengers. And we've had patients on it for about a year now. And the trial should be coming to a close soon. And the objective is to see, can it decrease dyskinesias and decrease off time. In other words, increase good on time for these patients. It is an oral medication, so it's convenient. One of the good things is that it does not have side effect profiles of dry mouth that we can have with the currently available amantadine product that we use. There's also another product being looked at for motor fluctuations in Parkinson's disease, and that inhibits the GPR6, which is observed in dopamine receptor positive cells in the median spiny neuron. And same concept, it's looking at could it decrease motor fluctuations and dyskinesias in patients. Now, dopamine agonists, dopamine agonists have recently fallen out of favor, not because of lack of efficacy, but mainly because of side effect profile. So, we used to use a lot more of ropinirole, pramipexole, or Neuropatch, but for a subset of patients, we know they can have compulsive disorders, or they can have, say, worsening of hallucinations or daytime sleepiness. Now, some of these side effects are thought to originate from the D2, D3 receptor stimulation. So there is a newer dopamine agonist called tavapadon, which is being developed. And this one is a D1, D5 receptor partial agonist, and it's only once a day dosing. The side effect profile so far in the trials, it's being looked at both as early monotherapy as well as add-on therapy. And the side effect profile is supposed to be better. with less of the daytime sleepiness, less compulsive or impulsive behavior, along with good efficacy. So this medication may be coming up before the FDA later this year or early next year for approval. Just one trial going on for multiple systems atrophy. I know there's two different trials going on in the country for MSA. But the trial that we are working on is looking at with Ono Pharmaceuticals, and it is a novel oral small molecule sphingosine 1 phosphate receptor agonist being developed for treatment of MSA. And I know Dr. Kimani's site is also involved in this trial. So basically, we're looking at effectiveness for this, for multiple doses of this in patients with MSA. Certainly, we need all the clinical trials we can for MSA because we don't have any effective product for MSA currently. Now, genetic testing in Parkinson's disease. Dr. Zabatin, I know, gave a talk with the Seattle Science Foundation previously, and it was an excellent talk on genetics of Parkinson's. So I'll keep it brief. But through PD Generation, which is a national genetics registry, patients can currently get genetic testing for free. So if patients are symptomatic, they can get genetic testing, and it's a one-time blood draw if they go to a site and wear a site, or patients can go online to PD Generation, and then they can just give their details and they receive a kit at home. It's actually a blood draw kit, but it's capillary collection, so they can do it themselves or with the help of a family member. And the blood is sent, and in about 3 to 4 months, they get the results through a genetics counselor. And it's looking for genetic variants in LOCK2 GBA and your pink one, Parkinson, SNCA. But the main genetics that impacts care at the present time is LOCK2 and GBA, because that's where the trials are the most developed to see if we could possibly alter disease progression. So that's a special interest, patients who have LOCK2 or GBA positive. Though in the future, they're also developing trials for these other less common genetic variants. And the objective of the trial is to create a genetic database and a sample repository so that these patients who test are aware of their genetic testing in case they want to enroll in clinical trials. And also, it's easier for sites to enroll so that we can, these trials that are specific for specific genetic mutations can be hard to enroll if patients are not genetically tested. So, and some eligible family members are also eligible to enroll. So if someone has a strong family history of Parkinson's, then they can also be tested. Now, the main differences or the main mutations we're looking at LOCK2 and GBA. So LOCK2 is an autosomal dominant mutation type. GBA1 is recessive. LOCK2 is the most common cause of familial PD, but still only 1 to 2% of all PD patients are suspected to have it, whereas GBA may be present in 5 to 10% of PD patients. With LOCK2, it's more involved in it's kinase that's involved in vesicle trafficking, whereas in GBA, there is lack of the GCase enzyme that breaks down cerebrosidase. LOCK2 is hyperactive kinase, whereas in GBA, there's loss of activity. So if we are looking at clinical trials, we have to look at decreasing kinase activity for your LOCK2 trials, whereas we have to look at increase in GCase activity for your GBA1 trials. Clinical features are similar to sporadic PD. In your LOCK2 patients, often milder, whereas for GBA1, they have faster cognitive decline and faster progression. So the current trials we have are Denali, the same compound is being looked at both by Denali as well as Biogen, because earlier they had a partnership, but they're doing their own clinical trials too. And then Neuron 23 is looking at LRRK2 driven. Now, what LRRK2 driven is, the thinking is that maybe LRRK2 is more involved in patients with LRRK2 mutations, but LRRK2 may be over involved in all patients with Parkinson's disease. So in the for Neuron 23, they are looking at they have their own diagnostic panel in which they are looking at patients who are LRRK2 driven, so some people are looking at all patients with Parkinson's looking to downregulate kinase. Some are looking at patients only with LRRK2 mutation. And some are looking at patients who are LRRK2 driven, which is some patients who they're running their own diagnostic panel and they've come up with their sort of diagnostic gene panel, which they think makes these patients LRRK2 driven. So Neuron 23 is looking at the LRRK2 driven population. For the GBA1 mutation, we have the gene therapy trial with Capsida, and I'll get into that in just a minute. So the whole concept of treating people differently with different genetic mutations brings us to precision medicine. So we have precision medicine, we have well, Luma, technically, it's not exactly precision medicine because we are looking at patients for all PD patients. However, the thinking is it may help patients who are LRRK2, who have the LRRK2 mutation more than patients who don't have LRRK2 mutation. And it's a reversible inhibitor of the LRRK2 kinase. The Beacon clinical trial is only enrolling patients who have LRRK2 mutation, any stage, whether they're newly diagnosed or further along. And the same compound that's being used in the Luma clinical trial is being used in this. Now, in some of these trials, one of the potential side effects is that it may possibly, in rat models, it's been, in some, there have been reports of type 2 pneumocytes being involved. No obvious human report so far. But because of that, we are having to do pulmonary function tests for these patients. And then there were some reports of elevated liver enzymes. So we are having to monitor the liver enzymes pretty closely within the first few months, and then about monthly or 2 monthly as they go further into the trial. Now, other promising therapies are stem cell. Now, we've heard several stem cell trials, right? I'm sure you have patients who've traveled to sites and gotten stem cells in different countries, or maybe even down the road from you somewhere. So one of the challenges with stem cells is that they've been delivered through intrathecal routes or IV routes, and there appears to be poor brain penetration. So the stem cell trials that are being looked at right now are directly delivered into the brain to see if that helps with that helps more than some of these other trials that have not proven to be that effective. Now, just a quick summary of stem cells. So stem cell therapy, you can have totipotent, pluripotent, multipotent, or unipotent cells. Totipotent can differentiate into all cell types, including those that form the placenta. Pluripotent, they can differentiate into almost any cell type within the body, but not the placenta. And then multipotent, limited range of cells, unipotent, only into one cell type. So when we are looking at therapy with Parkinson's, the focus is on pluripotent stem cells, not totipotent, because we don't care about like differentiation into the placenta, but we do want them to differentiate into dopaminergic stem cells. So some of the trials right now are looking at pluripotent stem cells. So stem cells, how to get these stem cells can be from different ways. They can be induced pluripotent stem cells, meaning you're using some other cell and then converting it into a stem cell. that then converts into a dopaminergic stem cell, or use human embryonic stem cells. Now, these stem cells that are being looked at are getting transplanted surgically into the putamen. Why into the putamen? Because direct delivery of stem cells into the putamen, these are derived from dopaminergic, direct delivery of stem cells derived dopaminergic neurons. It avoids the needs for these transplanted cells to grow long distance, to grow long axons from the substantia nigra. And it restores dopamine levels where functionally we need it, which is near the putamen. And then we can track these using PET scans, which shows the 18F DOPA uptake post-transplant. So generally, these are followed, you do pre-op and then you follow up 12 months, 18 months after stem cell transplant to see if the PET scan dopaminergic level, dopamine production increases. Now, there was this trial that was done in Japan. We were not part of the trial, but just as part of background. This trial was done in Japan using stem cells, and they used induced pluripotent stem cells. And so this was derived from HLA-matched donor blood, through which iPSC, these induced pluripotent stem cells, were produced. And then these were implanted into the brain. They followed these patients. There was no tumor formation, no immune rejection, but these patients were HLA type, so it was patients with the same HLA type that their blood was used. And importantly, no graft-induced dyskinesias, because we know that that was a problem when fetal cells were implanted. Some patients had graft-induced dyskinesia, so that was not seen. And mild and moderate adverse events were seen. And then when it was a small number of patients, however, when they did evaluate these patients, there was a trend towards their UPDRS Part 3's off scores to be improved by as much as 9.5 points. And the PET imaging showed up to 44% increase in fluorodopa uptake, suggesting that there was restoration of dopaminergic function. So this trial in Japan was the first iPSC-based trial that showed feasibility, safety, and preliminary functional benefit. And so larger clinical trials are planned. Now in the US, the trial that we are going to be part of as one of a national network of sites is a phase 1 human embryonic stem cell derived dopaminergic neurons. So the first trial has already been done, the phase 1, in which about 12 patients were enrolled in the trial. And this was a serial PET scans. The cells were surgically transplanted into the putamen. And similar to the Japanese trial, there was improvement. There was a trend towards improvement in MDS UPDRS. Again, small number of patients, not really powered for efficacy, but more for safety. But there was about 7-point improvement in the MDS UPDRS off time, improvement in dopaminergic uptake on PET scans, and the graft was still viable at 18 months and longer with no immune rejection. Now, no immune rejection with immunosuppression. So these patients did receive short-term steroid and then tacrolimus for immune suppression. So what we're going to be involved in the phase 2 trial. So it's actually a combined phase 2-3 trial. So after the phase 1, the FDA actually gave them expedited pathway in which they could combine their phase 2 and phase 3. So that's a trial that's going to be starting next month. So this is one of the most clinically advanced investigational therapies for stem cell that's being done in the US. So these dopamine producing, hopefully to replace dopamine producing nerve cells that are lost in PD. So these cells will be surgically implanted into the putamen. Now, it will be control, sham control compared with sham surgery. So initially what will happen is that some patients will get sham surgery and some will get actual therapy. And similar to how it was done in fetal cell transplant, the patients with this sham surgery will just get a small burr hole just in the outer table of the skull, not in the inner table. So that patients surgically, just externally, they can't make out if they got deeper penetration into the skull or no. That's to maintain the blind. And then approximately 18 months later, these patients will then get actual surgery. So one group will get sham, one will get actual, and then in 18 months, the ones who got sham will also get actual surgery. And these patients will need steroid and tacrolimus through the length of those 18 months to prevent immune rejection of the graft. Now, gene therapy, again, newer frontiers for Parkinson's. So the concept of gene therapy is we deliver working genes into brain cells and we try to instruct them to increase production of certain chemical mediators. So basically, a viral vector is being used. The viral vector is just being used sort of as a carrier to deliver something into the brain. These viruses are not replicating. And what we are doing is we are removing the viral capsid and replacing it with a gene that we want to deliver to the brain. So, and in most of these, the gene that we are putting is not incorporating into the host gene. So all you're doing is trying to carry a gene that you want to into the brain without it replicating into the host genome. So the two trials that we're looking at, one is intravenous infusion, in a one-time intravenous infusion of gene therapy in patients with GBA mutation. And then another trial looking at gene therapy in patients with motor fluctuations in Parkinson's, but that is surgically into the putamen. So gene therapy, like we discussed, 15% of PD patients can have GBA mutation, and these patients are more impaired than some of our other PD patients because they have faster cognitive decline, psychiatric symptoms, sleep disturbances. Sometimes age of onset can be earlier. And currently, we do not have any disease-modifying therapy. And there is decreased GCase activity and lysosomal dysfunction. So what we want to do is increase GCase production. So that's just the mechanism of GBA mutation and decreased GCase. So Capsida Biotherapeutics, they're working on a single dose of infusion of gene therapy in patients with GBA mutation. So the gene therapy consists of a recombinant AAV gene replacement therapy in which the virus genetic material is being removed and it's being packaged with the GBA transgene that encodes for the GCase enzyme. And it's what they've managed to do is they've managed to have good brain penetration with just IV infusion, but they've been able to de-target other organs such as the liver because some of the side effects in some of the other gene therapy trials have been due to liver targeting. So they've maximized targeting of the CNS and minimized targeting of the liver and just one single IV infusion. So this will be the first in human trial. And it's happening in some sites, including ours. And I believe Spokane, Dr. Aldridge's site is also doing it. GDNF is a potent neurotropic factor. There have been GDNF trials in Parkinson's going on for a long time, but they have been mostly intravenous or intranasal delivery. Again, the concept seems promising. The studies haven't really turned out to be positive. So one of the thinking has been maybe there just has been poor brain penetration. So now this trial is looking at delivering this directly into the brain using gene therapy. So again, AAV virus, And then there's a gene encoding GDNF that does not integrate into the patient's genome that's being delivered surgically into the brain. So that's the Regenerate trial for patients with any genetic status who are having motor fluctuations in Parkinson's disease. So if they're having approximately 2.5 hours of off time, then they are getting image-guided infusion of AAV2 GDNF into the putamen. One-time infusion. Again, there'll be controlled surgery. So one set will get just the burr hole without actual implantation, and then they'll get the actual implantation later. Some will get it the first time. And it's supposed to be less invasive. There's a specific reflux resistant cannula so that when you infuse, it doesn't come back and it stays in the space. There'll be no indwelling hardware, no repeat administrations. So just quick differences why about these two gene therapies. Capsid is more brain penetrant. That's why they're able to get away with IV infusion. Whereas for Ask Bio, these are chimeric AAV capsids that are rationally combined using different serotypes, but they do not have such good brain penetration through the IV route. That's why you need to put it directly into the brain. And some of the side effects from these gene therapy trials is from them targeting the liver or the dorsal root ganglion. But the purpose of these trials are hopefully targeting the CNS more and less the liver and the dorsal root ganglion, but we still have to monitor for these side effects. And then delivery route is different, like we discussed. Each therapy has its advantages. Obviously, IV is much more convenient, but we'll see what these trials show. The Ask Bio trial has already started recruitment nationally. There have been a handful of patients. We'll be enrolling our first patient soon. And Capsid is within the first few weeks, we may be having the first in human trial with this. So just to conclude, what we covered today was neuroprotective trials. We looked at different routes, including intravenous, oral routes, looking at various different mechanisms. Symptomatic, we've looked at oral therapies. We've looked at novel mechanisms involving stimulating different receptors. We've looked at novel routes, including subcutaneous infusions. And then stem cells delivered intraputamentally with human embryonic stem cells. And then gene therapy, looking at IV route, including intraputational GDNF for advanced PD. So with that, I'll end. I thank you so much for your attention, and I'm happy to take any questions.
Thank you, Dr. Agarwal. That was inspiring and so exciting. I'm so happy for the PD community here that you're doing all of these fantastic trials, and we will hopefully learn from your output and expand our research portfolio here as well. Any questions from the audience? While we're waiting, I have a ton of questions, but I think I'll save most of them for a coffee chat or something like that in the near future. I just have two important ones. Given you're running so many PD trials, how do you satisfy your recruitment goal for each trial? Because I'm assuming one patient is likely not going to be participating in more than one trial at a time.
So that's a great question. And we have, 5 movement disorders neurologists, and we have now a neuropharmacist too. And, we have neuropsychologists and our PT and OT and other teams that are also seeing patients, not just from Evergreen, but from other centers surrounding on the east side. So we do I think so we have almost 2,000 Parkinson's patients that we see at our center. And then what we do is we just routinely make patients aware of clinical trials that they have access to. So what we do is that At the end of the visit, we try. Again, the reality is sometimes you run behind and you don't have time, but we try at the end of the visit to just tell the patient you may be a candidate for this trial. And then we do have consent forms in the rooms, and we'll just hand the consent form. And through Epic, we send a message to our research team and say that please connect with this patient. So then we're not doing the whole pre-screen, but we've sort of, if I know this patient has motor fluctuations, I'll say you may be a candidate for a trial. I'll try to give the consent, and then I'll send a quick message through Epic. And most of my colleagues do the same. And that way, we've just sort of given a warm handoff, and then research and the patient can connect with each other. And then we have some displays about, our website has all our clinical trials, so we try to maintain that up to date so that patients can, and then on our website, there's a place where patients can, anyone, patients or patients from any place, they can just enter in their details and they can say, I'm interested in a clinical trial, and they get contacted.
Thank you. The fundamental thing is you have got 2,000 Parkinson's patients, so ample patients for all of these research trials, and obviously you've got 5 movement neurologists, which means that there's, a lot of foot traffic of Parkinson's patients coming and going.
And also now, a lot of the bigger sponsors, they actually work with third-party recruitment agencies. So, for instance, the patients with genetic mutations, right? Those are less, but they are spread of each site will have a few here and there. But there are patients who are doing self-genetic testing. So there are third-party vendors who can connect the patients with the sites. So if someone's GBA positive and they are somewhere where they don't have access to a clinical trial center, they can connect with these third-party vendors, and then they'll give information to the sites that are doing the trials. So that's been useful for these sort of genetic mutation trials. And we have been surprised that some patients who are getting tested are patients who do have a form of strong family history of Parkinson's. So they're actually very motivated. And so they've found us themselves. So they're going to clinicaltrials.gov and they're looking, finding sites, connecting with sites. So some of these patients are very motivated.
Yes, the remote recruitment is great. I don't want to take up the whole question hour. We still have 5 to 6 minutes. Any other questions from the audience? Okay. One more question. There is a raging debate in the movement disorders community that it is not just the misfolded alpha synuclein that causes a lot of mischief in the brain, but it is a depletion of the normal alpha synuclein, which is a very important synaptic protein, which is responsible for neurodegeneration. It's difficult to prove. I think it could be both. But what are your thoughts on having a therapy that just removes the misfolded alpha synuclein without actually repleting the brain with the normal alpha synuclein?
That's very true. And, it's easier to remove excess than make more of normal. So that's people are going for the target that they can achieve. But then some of the thinking is that when all of this misfolded alpha synuclein sort of clogs up the neuron, and that in turn may be decreasing the production of the normal alpha synuclein. So hopefully, once we remove some garbage out of the cell, they will have more room for normal. But is just removing aggregated alpha synuclein taking care of the whole problem? It's not. It's just taking away a slice of the problem. But hopefully just creating room for more of what's normal. Even in, say, Alzheimer's, right? I mean, just removing the amyloid is not all of it, but it still showed some decrease in progression. So maybe similar concept.
And if I understand correctly, these antibody therapies are not neuron penetrant. They are just removing the misfolded alpha-synuclein interstitially in between cells. Am I correct about that?
Exactly. Exactly. So the alpha-synuclein or the aggregated alpha-synuclein spreads from one nerve cell to another. So they're not penetrant into the cell, but during the time when it's moving from one nerve cell to another is where they bind to it.
Okay, got it. Uh, if there are no other questions, I'm going to thank Dr. Agarwal for spending her morning with us. This was very exciting. Thank you very much, Dr. Agarwal, and thank you all, and thank you, Swedish Science Foundation, for hosting this conference. Have a good morning, everybody. Thank you.